everyone. My name is Jose Darias with Barry University's College of Health and Wellness, and the primary objective of this project is to improve anesthesia provider confidence in Neuraxial Dexmedetomidine. What is Dexmedetomidine? Commonly known as brand name Precedex, but we'll be simply referring to it as Dex for the remainder of this presentation. Dex is an alpha-2 adrenergic receptor agonist that is 7 times more selective than clonidine. It inhibits pain by binding to the presynaptic receptors of the nociceptive afferent dorsal horn of the spinal cord. Neuraxial administration results in selective spinally mediated analgesia shown to result in a 10-fold potency in anti-nociception when administered intrathecally. Since it does not potentiate opioid-induced respiratory depression, should a patient require rescue analgesia via opioid administration, you should be able to do so without the increased vigilance of respiratory compromise. Due to the higher potency neuraxially than systemically, it reduces the systemic adverse effects, if any, such as sedation. It is a lipophilic molecule with a pKa of 7.1 with an octanol water partition coefficient of 2.8. Now, what does that mean, you might be wondering? It means that it will more rapidly reach its onset as opposed to hydrophilic compounds such as morphine. So what's the big deal? As in, what does the research show us? And how does it compare to other neuraxial adjuncts such as fentanyl or morphine? The literature was searched to compare Dex to other adjuncts including fentanyl, morphine, and placebo groups with saline. We will be discussing these data points moving forward, beginning with the time to reach a T10 dermatome block, which is the level of the umbilicus. Most lower extremity and lower abdominal surgeries using neuraxial anesthesia require a minimum of a T10 dermatomal level blockade. This includes cesarean sections. Dex produces a faster onset of both motor and sensory level blockade when compared to the opioid and placebo groups. Sensory blockade is achieved 19% sooner than fentanyl and 15% sooner than local anesthetics alone. Motor blockade is achieved 6% sooner than fentanyl and 15% sooner than the placebo groups. Undeniably, one can see the value of achieving the required sensory and motor blockade as quickly and as efficiently as possible, especially in emergent situations. The sooner the patient has been adequately anesthetized, the sooner the patient's surgical needs can be met. Next, the literature was searched to compare the time until the regression of the sensory and motor blockade by 2 dermatomal levels. This indicates that the spinal anesthetic is beginning to lose its effectiveness in providing surgical conditions. Dex was able to produce a sensory blockade that was 50% longer in duration before the regression when compared to opioid and local anesthetic groups. The regression of motor blockade was measured using a modified Bromage score. A Bromage score of 0 indicates that there is no block. 1 means that the patient can no longer move the hips. 2 shows that the patient cannot move the hips or knees. And 3 represents that the patient can no longer move the hips, knees, or ankles. Dex was able to produce a motor blockade that lasted 30% longer before reaching a Bromage score of 0 when compared to the other groups. Some considerations. While it may not always be favorable to have a prolonged motor blockade for intrathecal injections as a primary anesthetic, it also introduces it as an option where the analgesic duration previously was the limiting factor. For example, this prolonged motor blockade may be beneficial in hip replacement surgeries performed by a slower than average surgeon, where previously a spinal anesthetic as the primary anesthetic was excluded for its insufficient duration. Dex was searched and compared for its duration of analgesic effects when administered intrathecally. Dex was found to produce analgesia that lasted an average of 85 minutes longer than the other groups. In addition, Dex further prolonged the time in which a patient requested their first dose of rescue analgesic when compared to the other groups. Specifically, the Dex group presented a 50% increase in the duration of complete and effective analgesia. Narcotic-sparing techniques have been demonstrated to improve quality outcomes in patients without the usher of negative side effects that come from using intrathecal opioids that prolong patient hospital stays and increase healthcare costs. A critical aspect of exploring novel adjuncts or care techniques for patients is ensuring their safety in their application, or at least causing the least reasonable amount of harm to achieve an outcome. For this reason, the literature will search for the safety of Dex when administered in the intrathecal space. Dex was investigated for potential neurotoxic effects, and it was not found to produce any histopathological changes associated with neurotoxicity. The observable changes found of unspecified inflammation was attributed to the mechanical damage created by the insertion of the needle, an unavoidable repercussion of any spinal injection. One study, in fact, found that Dex was actually neuroprotective in the presence of trauma. Conversely, morphine was found to decrease cell viability and cause mitochondrial damage, albeit in doses higher than clinically indicated. Now, since intrathecal anesthesia is usually the primary anesthetic for cesarean sections, I looked at studies that searched its safety for the neonate, represented by APGAR scores at 1 and 5 minutes and umbilical cord transfer. Intrathecal Dex produced a neonatal APGAR scores identical to those of the placebo and opioid groups at 1 and 5 minutes. In addition, fetal umbilical cord blood samples were drawn and compared for pH, PaO2, and PaCO2, and no differences were noted. Dex was also clinically undetectable in these blood samples. These research findings imply that intrathecal Dex is safe to use in the intrathecal space in terms of neurotoxicity and does not cross over to the fetus in clinically detectable amounts, nor cause unfavorable neonatal conditions. When an anesthesia provider selects their primary anesthetic, they want to select a method that is appropriate and safe for the patient, but also provides the least adverse effects or deleterious sequelae. The primary side effects noted with intrathecal morphine that patients report as the most uncomfortable are the nausea and the pruritus, or itching. The other side effects commonly reported are shivering, hypotension, and most concerning, respiratory depression. The FDA actually requires a 24-hour monitoring period for these patients receiving intrathecal morphine, owing to its hydrophilicity and delayed onset of action. The advantages of Dex are that there have been no reports of respiratory depression or pruritus post-Dex injection. The Dex patients are also observed to experience significantly less prevalence of shivering and nausea. Of course, as with all things, there are pros and cons to each choice. The negative side effects that patients with Dex experience more often than with intrathecal opioids or local anesthetics alone include increased incidence of hypotension and bradycardia, although most research deemed it to be clinically insignificant. In addition, as I mentioned before, the prolonged motor blockade may not always be favorable depending on the setting or surgical context. It is up to you, the prudent anesthesia provider, to design and implement the best plan available for your patient and their clinical situation. So finally, what's the dose and how do I administer this? The most commonly administered doses amongst the research studies showed to be between 5 and 10 micrograms. One can simply acquire a single preservative-free 200 micrograms in 2 ml vial of Dex with a concentration of 100 micrograms per ml. Pull up 0.05 or 0.1 mLs respectively in a tuberculin syringe and add that to your local anesthetic dose, similar to Duramorph. Then administer your intrathecal anesthetic as normal. This slide and the next include the references used for this presentation. Thank you for taking the time to listen, and it is my hope that you either learned something about intrathecally administered Dex and/or that you will feel more comfortable using it in the future for your patients.